depende yan sa standard operational procedure ng inyong hospital. Yung admission sheet, nandoon siya sa first page. History and physical examination will follow. We have the physician's orders, the progress sheet. We have also the nurse's notes, the medication record, the vital signs, graphic sheet, input and output sheet. We also have the laboratory sheet, consultation, surgical or treatment consent, anesthesia and surgical record, specialized therapy records or progress notes, and specialized flow sheets. Okay. So itong mga to, lahat yan nakikita dun sa metal chart. Okay. Now, since wala pang charting ang RT, supposed to be dito siya papasok sa specialized therapy records or progress notes. Dahil nga, ang initial na assessment would come from the nurse and the doctors. So doon na tayo sa progress sheet or progress notes. Okay, so even though wala pa tayong participation dyan, lumalabas yan sa board exam. Okay, so let's continue with the general rules for medical record keeping. Entries on the patient's chart should be printed or handwritten. Nowadays, lahat ay handwritten muna. Okay, and yung ibang mga may form, i-fill upan na lang natin yon. After completing the account, sign the chart with one initial and your last name and your title. Ito lumabas to sa board exam. So yung institutional policy may require that supervisory personnel should countersign the student entries. So just in case na like sa nursing practice, ang nurse student na intern ay nag-charting. So nakapag-chart din ako dati nung nag-nursing ako. And then, after ko mag-chart, mag-cross sign yung aking CI para i-countersign niya kung ano man yung aking na-evaluate doon sa patient. Okay? So, yun. Kapag wala kayong CI, dapat yung staff, yung RT staff ang magka-counter sign. Do not use dito marks. When we say dito marks, ito yung may ganon, yung meron dalawang kuntil. After ka magsulat, tapos sabi mo, copy lang. Ibig sabihin, that indicates repetition of the above statement or something. Hindi pwede yon. Do not use dito marks dahil pwedeng mapasukan ng other chart yon, lalo na kung yung chart na yon would be used for legal purposes kung merong magsampa ng demanda doon sa nurse o doon sa doctor, tapos ikaw madamay ka dahil hindi mo kinumpleto yung iyong charting. So meron kang space dahil nag-dito mark ka lang or nag-repetition mark ka lang. Okay, do not erase. Erasures provide reason for question if the chart is used later in a court of law. If a mistake is made, a single line should be drawn through the mistake and the word error. Lumabas yan kanina sa quiz natin. Yun yung lumabas sa board exam. So, and the word error printed above it, then continue your charting in a normal manner. Okay. So, you have to correct. Kung may error doon, write the correct chart below it or above it and countersign it. Record after completing each task for the patient and sign your name correctly after each entry. Be exact in noting the time, effect, and results of all treatments and procedures. Chart patient's complaints and general behavior. Describe the type, location, onset, and duration of pain. Describe clearly and concisely the character and amount of secretions. Okay? So nakalagay dito sa baba, if you didn't document, you do not do it or you didn't do it. If you didn't document, ibig sabihin, good as no management, no treatment done nung time na yon. Kahit na pag ginawa mo pa, tapos chinarge mo pa yung patient, pero hindi ka nakapag-charting na done yon, that is considered as not done. And you could be liable kung may license ka na, may nangyari sa pasyente, kahit ginawa mo, ikaw pa rin ang pagbibintangan na hindi mo ginawa because hindi mo chinart. Okay? So you could be liable, answerable for patient neglect. Kaya mo ngayon yung iyong lisensya dahil sa iyong negligence. Okay, leave no black lines in the charting. Draw a line through the center of an empty line or a part of a line. This prevents charting by someone else in an area assigned by you. Lalo na kung nasa dulo na ng form o nung sheet na yon, yung iyong chart, then dapat lagyan mo na ng linya para ibig sabihin, hindi na yan pwedeng sulatan. Use of standard abbreviations. Okay, so as respiratory therapists, you are very particular with the different medical terminologies na ginagamit natin sa RT. Dapat alam mo kung ano yung abbreviations noon, kung ano yon, para saan yon, ano ba yung STAT. STAT means immediately. Ano ba yung WHO? Sa charting, hindi yan World Health Organization. Okay, waking hours only. Ano ba yung MGA? May go home. So use the standard abbreviation, Q4, Q2, BID, okay, TID, tres inje, bis inje, quarte inje, lahat yon dapat alam mo kung ano ang ibig sabihin. Okay, use the present tense, never use the future tense, as in like patient to receive treatment after lunch. Walang ganon. Okay, so hindi pwede na anticipation. Lahat yon dapat ginawa na use the present tense. Okay, baka dito pa lang sa standard abbreviation, pagka nag-chart tayo, yung pulmonology, hanggang ngayon, di mo pa alam kung nasan doon yung O at yung U. Pulmonology. Okay? So doon sa nurse station, meron silang medical dictionary doon. Meron yan. Kasama yan doon sa kanilang setup. Sa pulmonary unit, supposed to be, meron din kayong medical dictionary doon at merong mga RT books doon. Kasama yon sa mini library ng isang pulmonary unit. So, you check on the correct abbreviations kung ikaw ay duda or correct spelling kung ikaw ay duda doon sa iyong sinulat. Okay, so spell correctly. If you are not sure about the spelling of a word, use a dictionary to look it up. Document conversations with the patient or other healthcare providers that you feel are important. So you have to inform the patient's physician or nurse that the patient seems confused or more short of breath. So kung nakita mo na pwede ngang mag-collapse o magkaroon ng cold blue later on, then you have to inform the nurse. Nailagay mo na rin doon sa documentation mo and na verbally na sabi mo na rin doon sa nurse mismo. Note, the documentation, no documentation means the treatment was not given, and that is also known as patient neglect. Okay, for the POMR, Problem-Oriented Medical Record. So this is from your EGANS. Ang ginagamit ay Problem-Oriented Medical Record. But in the practice dito sa atin, ang ginagamit na natin for charting ng progress notes is SOAP. Now, meron daw sa St. Luke's nag-chart na sila, sa ibang hospital nag-chart na rin sila, and I have experienced charting also sa Pulmo Rehab ng Lung Center. So may mga times na yung RT naggagawa na rin ng SOAP, Subjective Objective Assessment and Plan. As contrast dito sa database, problem list, plan, and progress notes under EGANS. Okay, so the outline of a complete health history. So for your medical history, importante na alam mo yung mga contents mo at yung mga ibig sabihin nun at mga i-chart mo doon. For the demographic data, ito yung mga information obtained upon admission. So, ano yung name ng patient, age, address, date of place, okay? Yung kanyang race, nationality, marital status, religion, nandiyan na rin yung occupation niya, nakalagay sa demographic data, and source of referral, kung referred by ganitong doctor or referred from this unit to the next unit. So, nandun yon. And of course, nandyan yung date and source of history kung sino yung na-interview during the patient's admission. And then followed by brief description of the patient's condition. Ano ba yung brief description ng patient's condition? At that time, ito yung HPI, yung history ng patient's condition na nakasummarize lang. Okay? In summary form. Yan yon, yung patient's condition. Or, pwede rin, yan yung sa doctor's progress notes, yan yung yung tinatawag na initial assessment ng doctor or initial impression of the disease ng doctor. Okay? Then, next is the chief complaint. Of course, yung chief complaint, yun yung reason for seeking the treatment or seeking confinement. And then next is the HPI. HPI, of course, is the history of present illness. PMH is the past medical history, family history, social, environmental, occupational, and social, environmental, personal, and occupational history. And then the pang-seventh actually yung ROS, review of systems. So all systems, pertinent symptoms na hindi na focus doon sa ating chief complaint na pwedeng ma-identify related or pertinent doon sa respiratory system, pwede nating isama. Yung sa ROS, these are all symptoms, pertinent symptoms. Hindi yan mga signs. Like for example, sa CNS, headache. Okay? Positive for headache, negative for headache. Positive for vomiting, negative for vomiting, nausea, etc. Okay, so what are these? Yung ating outline of complete health history. Again, your demographic data, name of patient, age, address, birth date, okay? Yung kanyang nationality, marital status, religion, occupation, and yung source ng history taking, and of course yung date. And then followed by chief complaint. Yung chief complaint is yung ating subjective complaint. Then we have here the history of present illness. For the history of present illness, we should ask the patient according to onset. Yung time, type ng sakit, chest pain, yung onset niya ng oras, ano yung naramdaman ng pasyente. And yung kanyang source, bakit saan niya naramdaman yon? Nung ba siya, nag-travel siya? Ano kaya ay nung naliligo siya? Ano yung setting? Okay? Ano kaya nung nag-work siya? Then, you write there the onset with the type and source ng setting then for that pain. And then, the frequency and duration of symptoms. So, gaano kadalas and gaano tumatagal yung sakit niya, if it is chest pain, or if it is cough, or productive cough, or kung dyspnea yon. Okay, under HPI, aside from onset, the frequency and duration of symptom, you will also write there the location and radiation of pain. Okay, so saan yung masakit? Sa middle chest ba? And then, nagre-radiate ba hanggang sa likod? Nagre-radiate ba sa left upper extremities? Or nagre-radiate ba sa lower extremities? So saan yung kanyang radiation? And then, followed by severity. Gaano ka grabe yung kanyang quantity. Severity, minsan iaano mo yung kanyang quality ng severity, character na rin as to 1 to 10. 10 being the worst, ano po yung naramdaman yung sakit? Pakirate niyo po 1 and 10 yung pinakamasakit. So sabi niya ay 5. Okay? Sabi niya ay 10. So kung 10 na yan, nagmumura na yan, umiiyak na yan, hindi na maintindihan yung nararamdaman because 10 is the pinaka-worst, pinakamasakit. And then in the HPI, you will also include aggravating factors or yung alleviating factors. Ano ba yung nakapagpalala ng kanyang kondisyon? Nung yumuko siya, lalong nahilo, lalong sumakit yung kanyang chest. Ano kaya na-alleviate siya nung nag-take siya ng aspirin, for example, or na-alleviate siya nung nag-nebulize siya. Okay? So you write down the aggravating and the alleviating factors. Also, the associated manifestation. Okay? Number 4 is the past medical history. So kung bata yung pasyente natin na nangangailangan ng RT management, dapat na isulat natin yung kanyang immunization. So kumpleto ba yung immunization niya? That will affect also kung meron siyang possible siya or suspected siya for pneumonia. Okay? So kung hindi niya na kumpleto yung mga immunization, pwede ngang weak ang kanyang lung or yung kanyang respiratory system or affected yung kanyang general condition. Okay? What else? Yung allergy niya. So dapat na isulat natin dyan kung allergic sa food, sa medication, yung ating pasyente. And of course, sa family history, importante na na-document, sa past medical history, importante na document natin in chronological order yung kanyang past confinement or past hospitalization from the pinaka luma hanggang sa pinaka bago or latest or current na hospitalization. Okay? So that is for past medical history. And then for family history, importante na ma-document natin yung meron ba siyang genetic disease or yung mga nakakahawang disease or familial disease. Okay, so may mga genetically transferred na disease like cancer, diabetes, okay? Lahat yan dapat na-document sa family history. And meron naman din tayong tinatawag na familial history. Okay? Not hereditary, not passed through the genes, pero common among family members. Like for example, common na mahina yung baga nila, common na mabilis silang magkaroon ng colds and flu, common na atakin sila sa lungs ng mga pneumonia and pulmonary tuberculosis. So these are your familial history. So you take down notes of the hereditary and the familial disease. And also, you have to take down notes kung ano yung effect ng family disease nila sa present na nararamdaman ng pasyente. Kung ano yung impact, kung paano siya nagre-recover, kung paano niya tinatanggap yung family disease nila or family history ng genetic disease nila. Okay? So minsan naman, nahihiya siya dahil may PTB yung lolo-lolo niya hanggang yung parents niya. Akala niya ang PTB is sakit ng mahirap or sakit ng talagang kulang sa sustansya. Okay? Kaya kinahihiya niya. Ano kaya nahihiya siya dahil meron silang history ng HIV and others. Okay? And number 6, we have personal, social, environmental, occupational history. So dito, ilalagay na natin yung mga personal hobby, okay, vices ng ating pasyente, kung ano yung madalas na pinagkakaabalahan niya. Okay, mahilig ba yan na mag-party and alcohol drinks, ano kaya, smoker, yung kanilang group, social, so mahilig ba yan na laging nasa labas, the travel and others, environmental, yung kanilang tinitiran ba, congested ba, or masikip ba, and how many family members yung nandoon na nag-aagawan doon sa ventilation, doon sa room. Okay? Environmental din, kung saan sila nakatira, kung yan ba ay malapit sa pabrika, malapit sa mining, malapit sa kalsada, sa highway, exposed sila sa mga pollution and others, or malapit sa yung mga sunugan ng basura. Okay, so lahat yan dapat nasa personal, social, environmental, and of course, yung kanyang occupational history, ano yung mga naging trabaho ng pasyente natin that can be related or may relevance doon sa kanyang present condition. Baka naman kasi minor siya. So, exposed talaga siya sa pneumoconiosis. Ano kaya ay meron siyang or silicosis? Ano kaya ay nagtatrabaho siya sa pabrika ng cotton? Okay? So, yun. The occupational history could also be related doon sa kanyang present na condition. And the seventh is the review of system. For the review of systems, you have to write down the pertinent positive and negative symptom from the CNS, cardiovascular system, from the respiratory system na hindi na-mention doon sa chief complaint, and then from the gastrointestinal tract system, genitourinary tract system, and also sa musculoskeletal system. Okay, hindi lang yung pertinent positive, pertinent negative din para makita na ikaw ay magaling na communicator and magaling na history taker. Okay. Next we have here the SOAP, the subjective, objective assessment and the plan. Okay, so for the subjective, ano nga ulit yung ating subjective complaint? These are data provided by the patient regarding his or her feeling or concerns. Okay, so nilagay mo dyan, chest pain. Objective findings, data that can be measured, factually described, or collected from other professional reports or test results. Okay, so ano yung mga objective findings natin? Starting with the vital signs, yung kanyang respiratory rate. Anong significant ng kanyang respiratory rate? Is it, meron ba siyang tachypnea, bradypnea? The patient has eupnea, normal naman yung kanyang breathing at 12 breaths per minute. The patient has respiratory rate na 8 breaths per minute but presenting with anong types ng kanyang breathing pattern. Isulat niyo yan sa kanyang respiratory rate din. For the pulse rate, anong significance ng ating pulse rate? Is the patient presenting with poor circulation or good circulation? May tachycardia ba siya? Bradycardia ba yung patient mo? Or the patient has normocardia or normal ang kanyang pulse rate at 70 breaths per minute. Then for the temperature, is the patient using pyretic agent? Antipyretic agent like Biogesic, okay? Calpol, yes or no? Ano yung temperature niya? Meron bang lagnat yung patient natin? Is the patient has hyperthermia or hypothermia? Lagay mo dyan kung ano yung tinetake niyang gamot. And for blood pressure, of course, dapat na-signify natin kung ang patient natin has hypotension or hypertension. Ano yung ating pang-fifth vital sign? Of course, as respiratory therapists, dapat nandiyan yung ating SpO2. Okay? So the oxygen saturation using a pulse oximeter, mami-measure natin yan if the patient has desaturation or over ang kanyang saturation. Okay? So for desaturation, kapag bumaba yan sa 90%, then there is already desaturation. Kasi meron niyang upper and lower limit na correction factor para sa ating pulse oximeter. So more or less, SpO2 as compared to your SaO2, you have 5% na difference. Okay? Upper or lower limit. And then kapag naman ang yung SaO2 as compared to your PaO2, meron niyang difference na ilang percent. More or less 2 to 3%. Okay? Then, after the vital signs monitoring, dapat na-check natin ang general survey. For the general survey of the patient, okay, so upon seeing the patient, we have checked yung kanyang level of consciousness. Later on, may slide tayo ng different types of level of consciousness. So is the patient alert, active, comatose, non-comatose, lethargic, confused, etc.? Is the patient cooperative or non-cooperative? Ayaw makipag-coopera ng pasyente mo. Ini-interview mo, ayaw kang sagutin, okay? Pinapag-nebulize mo, tinatakpan yung ilong. So, yun, lagay nyo yun sa cooperative or non-cooperative. Is the patient bedbound or bedridden? So, bedridden, kung ang patient mo ay semi-comatose, comatose, so highly dependent siya doon sa kanyang watcher. Okay? Pagka bedbound naman, ibig sabihin, yes, nakakonfine na sa bed yung patient but can do activities of daily living. The patient can comb his or her hair, can eat, okay, can brush teeth, ano pa, can move within the bed. So that is bedbound. Kaya naman niya yung other activities, daily activities. Okay? Position ng patient mo. Nung nakita mo yung patient mo, lagi siyang naka-high back rest. Bakit kaya naka-high back rest? So nagsususpect ka na, nahirap talaga siyang huminga dahil pag nakahiga, nagdi-difficulty of breathing siya. Sorry. And then, you check further kung ang pasyente mo ay may good posture. So, good or bad posture ba? Baka naman nakahukot yung patient mo, naka-flex yung kanyang neck, so that maghihirapan nga siyang huminga. There is difficulty of breathing because of the bad posture. Okay? Ano pa? Body build ng patient mo. For the body build of your patient, dapat na-check mo kung fair ba, poor ba, or good yung kanyang body build. Okay? So, kung mataba ba, payat ba, obese ba, nandoon din sa general survey yon. Nourishment, fairly nourished, badly nourished, i-check mo yung kanyang BMI para ma-sure mo kung siya ba ay sa body build and nourishment may kinalaman na obese yung patient mo or undernourished yung patient mo. And then inspection of extremities, especially yung skin color ng patient. Okay? So, meron tayong central cyanosis and peripheral cyanosis. Kung nagbo-bluish discoloration nga ba yung kanyang chest, yung kanyang lips, yung kanyang eyes, yung kanyang nose, and then yung extremities. Okay, what else? Chinek mo dyan sa extremities niya kung meron siyang digital clubbing, okay, or may pedal edema. So digital clubbing will show na meron nga siyang chronic disease. Or pwedeng smoker yung patient at merong heart problem. So hindi maganda na yung kanyang circulation and perfusion. Kaya meron siyang digital clubbing. And then you check further kung meron nga bang edema. So the presence of edema will tell us na poor ang circulation ng patient. And there is imbalance sa kanyang mga electrolytes. Why? Nagkakaroon na ng leakage ng fluid from the saan yon? ICF into ECF. Okay? So yung compartment na dalawa na yon, kapag yung sodium, potassium, calcium, magnesium, okay, nagkaroon ng imbalance, so mag-exit yung electrolyte found in the ECF and the ICF, so lalabas siya dun sa ECF and form an edema. So, ang tinetest natin sa patient, yung sa digital clubbing, chinecheck natin kung merong hole pa between two nails. Okay, that is clubbing. But for pedal edema, okay, chinecheck mo kung pitting or non-pitting edema. So, kung nagre-respond ba kapag nag-apply ka ng pressure doon sa skin niya, doon sa kanyang paa or doon sa kanyang tuhod, kung nagkakaroon pa rin ba ng edema, and i-evaluate mo yung edema niya kung nasa baba lang sa ankle area, okay, sa knee area, or dito na sa leg area, or sa paakyat na in the proximal ng lower extremity mo. Okay? So, pedal edema. Jugular vein, if there's a presence of jugular vein habang nagsasalita o during the interview and a normal voice lang, meron na siyang jugular vein. So that means there is increase in the venous pressure due to deficiency in the oxygen. So yung kanyang oxygenation is poor na. And then you check also yung other gadgets na attached sa patient mo, like oxygen therapy, ilang liters per minute, ilan ang FiO2, dapat naisulat mo yan sa charting kung mag-chart na ang RT. Okay. And of course, yung IV lines placement, nasa dorsal ba o nasa ventral. And importante ito, kapag mag-ABG tayo, kung saan tayo kukuha. Sa right ba o sa left, iiwasan natin yung mga merong naka-attach na lines or placement diyan sa kanyang kamay. Okay, para hindi matrauma masyado yung left or right niya. Level of dyspnea or level of respiratory distress. So, we know the grade of dyspnea, grade 1, grade 2, grade 3, grade 4, and grade 5. Ginagamit natin yan to determine the level of respiratory distress. So, how will you know that the patient has? Lagi natin nakikita sa chart eh. Kung nagbabasa kayo ng chart, nakikita nyo doon, document ng doctor, mild respiratory distress, moderate respiratory distress, severe respiratory distress, and very severe respiratory distress. Okay? Saan nanggagaling yung category niya? So, yung sa isang nabasa ko, yung level of dyspnea or grade of dyspnea could be used for this one. Grade 1 and grade 2 would be for mild respiratory distress. Grade 3 is for moderate respiratory distress. Grade 4 is for severe respiratory distress, and grade 5 is for very severe respiratory distress. Okay? So, doon nakuha yung level of respiratory distress. Okay, next we have the cough. Cough, one of the most common symptoms in patients with pulmonary disease. So these are now your, meron previous to. Yon. These are your common cardiopulmonary symptoms. So as RT, we should know what dyspnea is. Ang dyspnea is the sensation, di ba, that occurs when breathing effort is excessive minsan or minsan naman ay kulang. Increase or decrease ang kanyang breathing. Dyspnea or shortness of breathing increased work of breathing. Pag sinabi nating work of breathing, so may kinalaman yung lung compliance niya, yung elastance ng lungs niya, kung meron nga bang problema doon. Okay? Kung ang pasyente natin ay may underlying pneumonia, may underlying consolidation and fibrosis, pulmonary fibrosis, so tumitigas. So magkakaroon nga yan ng effect doon sa kanyang lung compliance and lung elastance. And then of course, yung ating respiratory rate and yung kanyang pattern of breathing. Yung pattern of breathing niya, normal ba yung pattern of breathing? Okay, yung aeration niya ba, 1:2, 1:3? Okay, yung patient ba gumagamit ng accessory muscles of respiration during breathing niya na nakita mo? So, inassess mo rin yon. The use of accessory muscles during breathing. Yung breathing ba niya ay paradoxical or yung diaphragmatic breather or thoracic breather yung patient. Okay? Next is orthopnea. So kasama yan sa cardiopulmonary symptoms natin. But in general nga kasi kinakategorize natin under dyspnea. But for specifically, common yung cardiopulmonary symptom na orthopnea. For this patient, please take down notes of the diseases na meron itong orthopnea. This is common in patient with congestive heart failure, dahil may sudden increase in venous return sila, then failing ang left ventricle nila and unable to accommodate yung congestion niya ng blood, kaya nagdi-dyspnea siya. So common for CHF and bilateral diaphragmatic paralysis. Okay, so how will we assess if it is orthopnea? Kung nagkakaroon siya ng difficulty of breathing in reclining position. Okay, difficulty of breathing in supine position or reclining position or in a recumbent position. Kapag nakahiga, may difficulty of breathing and we instruct patient to use at least 3 pillows na ilalagay sa backrest niya or sa likod niya para makahinga siya ng maayos. Next, we have diplotipnea. Diplotipnea is shortness of breathing in upright position. So, ito naman, kabaliktaran ng orthopnea, nakahiga, may nahirapang huminga. Ang platipnea, nahirapang huminga kapag nakaupo, kapag nakatayo, kapag naka-upright yung kanilang chest. So, this is in cases of chronic liver disease. Kaya ang nire-recommend ay medyo naka-recline na position naman yung patient mo. So, common in chronic liver disease, arteriovenous malformation in the lung, and it can be accompanied by orthodoxia. Ano yung orthodoxia? This is oxygen desaturation on assuming an upright position. Okay? So that is under platipnea. Okay, so what if you will be asked, ano yung bluish discoloration of skin seen in extremities due to poor perfusion of blood? A, central cyanosis. B, acrocyanosis. C, peripheral cyanosis. Or D, B and C. Okay, again, this is bluish discoloration of the extremities due to poor perfusion of blood. A, central cyanosis. B, acrocyanosis. C, peripheral cyanosis. Or letter D, B and C. And the answer is letter D or dog. So this is acro, extremity cyanosis, and peripheral cyanosis. So B and C. Next, cardiopulmonary symptom is cough that we have talked about a while ago. One of the most common symptom in patient with pulmonary disease. So sabi natin, cough is considered as pathologic kung iyan ay persistent. Niyak-niyak, walang dahilan, ubo ng ubo, maybe because of Hindi dahil sa nakasinghot ng usok or nakaamoy ng cigarette smoke or something. So cough that is persistent dahil merong underlying disease ay pathologic. Okay? If it is transient, as an effect lang or uh, reflex lang ng iyong trachea o ng iyong bronchial o ng iyong carina dahil may foreign object o merong foreign smoke, then that is transient and that is still normal. Okay? So kanina na-mention natin na ang cough could be chronic or acute. Acute kung sudden, so ibig sabihin, biglaan na nagkaroon ng cough in less than 3 months. Okay? And yung chronic naman, in more than 3 months. Yung iba pa nga, 2 weeks lang weeks lang. Okay? So 2 weeks or 3 weeks, more than 2 or 3 weeks, chronic cough na yun sa ibang libro. Okay, anyway, hindi naman sumalabas yung ganyang tanong. Anyway, yung chronic cough, sabi natin kanina, could be coming from the gastroesophageal reflux na hindi magagamot ng bronchodilator o ng antibiotics dahil kailangan mo nang i-resolve yung kanyang acidity ng stomach. Okay, so chronic cough also could be due to chronic bronchitis, chronic asthma, okay, or cigarette smoking. Next is sputum production. So sputum production, phlegm versus sputum. Phlegm, mucus from the tracheobronchial tree that has not been contaminated by oral secretion. So no presence of bubbles or saliva. So that is dapat na separate yun pagka nag-collect ka ng phlegm o ng sputum. Sputum mucus that comes from the lung but passes through the mouth as it is expectorated. So, ang sputum natin could be a purulent type. Purulent sputum contains pus cells. So, example natin yan ng bacterial infection. Meron siyang thick, colored, and sticky. So, kapag yung ating sputum has this purulent sputum, dapat mag-suspect na tayo for some bacterial infection. Fetid, medyo foul-smelling sputum siya. Mucoid, clear and thick in cases of asthma. Okay? Also, pwede rin nating i-categorize yung ating mga sputum production, phlegm, and sputum na to according to color. Okay? So take down notes na kapag daw ang sputum color ay white and translucent, that is still normal. Okay? Kapag ang iyong sputum production, medyo yellowish na siya, ibig sabihin, there's a presence of infection, but the body is fighting. Okay? From clear, nag-persist yung kanyang cough, nagkaroon ng light yellow, so still, nagpa-fight for infection yung ating katawan. Umaandar yung ating mga defense mechanism. Pero once, itong ating plema naging dark yellow and medyo may buo-buo siya, may bukol-bukol pa siya, then there is a presence of infection na hindi na kaya ng ating katawan. Okay, ibig sabihin, kailangan na natin na inuman ng gamot. And if the sputum color is green, possible na dahil meron ng dating retained secretion. Okay, so yan yung nagsususpect tayo for Pseudomonas aeruginosa. But green, mostly, ay merong retained secretion. Kung brown naman yung kanyang sputum, from yellow, naging brown, then lumala na yung kanyang infection. Or ano kaya, iyan ay due to hemoptysis o merong old blood na hindi na ilabas during spitting of blood or hemoptysis. Naging brown. And then red nga is for fresh blood. So fresh blood na nag-hemoptysize yung patient mo, maybe due to end stage na ng pulmonary tuberculosis or yung severe case ng tuberculosis, or pwede rin doon sa mga merong emphysema na nag-burst na yung kanilang lung parenchyma and others. Okay, next we have under. Kanina pinag-uusapan natin, andito pa lang tayo sa objective findings. Okay, under SO. Objective findings, we have the vital signs, general survey, then dahil nga na-discuss natin yung ating common cardiopulmonary symptoms and ano yung other detailed na pwede nating maging objective findings in relation to our symptom. Yan na yun, na-mention na natin. Okay. Under sa objective findings, kanina, na-discuss natin yung vital signs. And for further study of your vital signs, these are your numerical values that signify the functional capacity of an organ or tissue. So initial assessment measurement, and this is what we call as the cardinal sign. Pag sinabi mong cardinal sign, so meron siyang determination kung lumalala nga ba yung condition ng patient mo according dun sa measured na respiratory rate, temperature, then your body, your blood pressure, pulse rate, and the SpO2. Okay? So cardinal sign siya. Importance, it will provide important diagnostic information, and this one is the first clue of adverse reaction to treatment or positive effect to treatment. Baseline condition to which a plan of care will develop, and recording and documentation purposes. So every 4 hours, nagba-vital signs monitoring ang nurse. Ikaw naman na RT, nakikikopya lang. Dapat nag-assess ka rin, especially of respiratory rate, pulse rate, and blood pressure during your RT management. How often do we take vital signs? So for nurse purposes, ganito yung kanilang ginagawa. But for RT, every time lang na magmamanage tayo sa patient dapat. The body temperature. O lumabas ito si Gabriel Daniel Fahrenheit. Of course, siya yung nakadiskubre ng thermometer. And we know that this fever with increased temperature, of course, is caused by a disease. Common na ito in viral or in bacterial infection. And with this vital signs, body temperature, lumabas dun sa board exam yung hypothalamus, which is the center for heat loss and heat gain. Okay, so kapag ang hypothalamus ang naapektuhan due to car accident, then yung heat loss and heat gain mo ay affected, and magpo-cause yan ng critical condition sa patient. Kailangan yan ma-resolve at makorek. For the fluctuation over 24 hours, so meron tayong continuous, constant, intermittent, remittent, relapsing na type ng fluctuation. Okay. So, sa respiratory side, tinitingnan lang natin kung ang kanyang fever ay continuous nga ba. Okay. So, we're checking on possibility na merong ang pneumonia kaya or may underlying na pulmonary tuberculosis. Okay, kasi lalo na kung ang kanyang body temperature ay more than 0.1 degrees centigrade to 0.2 degrees centigrade lang ang elevation. So minsan kasi walang lagnat na nagpe-present doon, lalo na sa asthma, walang lagnat. Intermittent, okay, hindi na yan, hindi na importante sa RT. yung remittent marked by peaks and valleys but body temperature does not return. Ano natin to, basis natin to, lalo na kung ang pasyente mo ay nahihirapang huminga, difficulty of breathing because of high temperature, very high temperature. We all know that the body temperature will have an effect on the oxygenation and carbon dioxide production ng ating pasyente. For every 1 degree increase in body temperature, there is 10 mmHg increase in consumption ng ating oxygen dapat. So dapat mag-i-increase ang ating consumption ng oxygen. And for every 1 degree increase in body temperature, there is overproduction ng 10 mmHg naman sa kanyang carbon dioxide o yung kanyang PaCO2. So ibig sabihin, kapag may lagnat, yung PaO2 niya, understood na yon na bababa siya ng 10 mmHg. And tataas naman yung carbon dioxide niya ng 10 mmHg rin. Hypothermia, cold environment, trauma to the hypothalamus. So we are assessing this one kung ang pasyente natin is under ventilatory support. Kapag under ventilatory support yung patient natin at hypothermic siya, then we need to increase the humidifier temperature setting. Dapat mataas yan sa 37 degrees centigrade. Why? Dahil nga yung pasyente mo ay nalalamig na, yung incoming air papunta sa kanya, kapag malamig pa, lalo nang magkakaroon ng problema yung pasyente mo. So kailangan mainitan yan, and para maiwasan natin na magkaroon ng congestion doon sa kanyang airway, para hindi magkulangot yung ating pasyente kapag naka-ventilatory support. Yung mga secretions niya, hindi yun matutunaw. Okay, instead, mabubuo-buo yun. Yun yung tinatawag natin na nagkukulangot doon sa ating tubing. Okay? So, kailangan i-increase mo yung humidifier pag hypothermic yung patient mo. So, hypothermia, we all know, is less than 34 degrees centigrade. Yan ay very fatal na. And hyperpyrexia, or very high fever, is at 39 to 40 degrees centigrade. Okay, importance ng ating body temperature again, this is to indicate the basal metabolic function of the body, to check for the acidity of the blood. May kinalaman yan sa result ng kanyang pH and ng PaO2 niya and PaCO2 niya. And temperature changes will affect enzymatic reaction. So what are the contraindications for taking vital signs? Sa rectal, syempre kapag may diarrhea or nag-undergo ng rectal surgery yung patient natin, rectal disease, hindi pwede. Sa oral, kung ang pasyente natin ay epileptic, unconscious, or confused, hindi pwede. And what are the factors that will affect variation of body temperature? Please take down notes. May itong mga factors na to will also affect yung ating pulse rate, blood pressure, and yung ating respiratory rate. Hormonal activity, of course, will affect the body temperature. Pag nagme-menstruation, mas mataas ang body temperature. Okay, time of the day is late afternoon. Siyempre, pagod na from work. Exercise, there is increase in body temperature. The season, so we all know that in a cold area or venue, nagbabasoconstriction tayo, kaya decrease ang kanyang blood supply. Okay, so close yung kanyang blood vessels minsan, and warm area, nagkakaroon naman ng vasodilation or open yung ating blood vessels. So the food, spicy food, carbohydrates would also be affecting the body temperature, sex, course, and age. Okay, so alam natin itong mga types of thermometer natin. We have rectal, oral, axilla, digital, may app base na, and merong pang baby na pacifier. So no need to further discuss it. Okay, for the stages of fever, just read on this, the period of an onset of invasion, fastidium, and effervescence. Okay, hindi na yan lalabas. Itong formula, possible na lumabas ito dahil lumabas na yan noong mga 2014, 2015. Okay, so paki-memorize yung iyong degrees Fahrenheit and degrees centigrade. Yan, formula. Okay. And moving on to pulse rate, we know that this is the alternate contraction and expansion of the artery corresponding to the heart. So here we are evaluating the strength and the rhythm of the pulse. Okay, tinitingnan natin kung mabilis ba, malakas ba, at nasa pattern ba ng pagbigay ng kanyang cardiac output and yung flow ng blood. For the rate, for the rhythm, for the volume, yan dapat yung ating na-monitor. And normal is a strong pulsation. Okay? So imperceptible, steady ba or feeble, bounding or tension. Just read on that. Okay, so we know that the different pulse sites for pulse rate monitoring are the following. Siyam yan, the radial, temporal, carotid, brachial, femoral, popliteal, apical, and the posterior tibial. So lahat yan, pinapalpate natin except for the apical pulse. For the apical pulse, para ka na rin nagmo-monitor ng heart rate. Okay? So saan mo yan chine-check yung apical pulse na yan? So you are checking it using your stethoscope. The bell of the stethoscope placed doon sa apex o doon sa dulo ng heart. Okay? Doon sa pinaka patusok ng heart. This is your apical pulse or the point of maximum impulse. Your apical PMI is located at the fifth, kailan yan? Sa ibang libro, fourth, or sa ibang libro, between fourth to fifth ICS mid-clavicular line. Okay, so your PMI is located between the fourth and the fifth ICS mid-clavicular line. So diyan natin binibilang yung kanyang heart rate and yung kanyang pulse rate. Okay? So usually lumalabas sa board exam ay fifth ICS. And dapat alam natin yung difference itong pulsus alterans and pulsus paradoxus. Okay? Lagi yung lumalabas sa board exam. Ang nakalagay doon is anong cases or condition ng patient na merong pulsus alterans. So those with left side heart failure, yan, meron siyang pulsus alterans. Alternating succession of strong and weak pulses suggests left-sided heart failure and usually is not related to respiratory disease or ito ay hindi affected ng respiratory conditions. Pulsus paradoxus naman, this is a notable decrease in pulse strength during inhalation. So kapag nakakita kayo ng merong pulse rate affected during inhalation or during paradoxical pulse is what we call as pulsus paradoxus. This is common in patients with obstructive pulmonary disease, especially yung mga may acute asthma, okay, may mechanical restriction sa heart, pumping action, those with pericarditis or cardiac tamponade. Take down notes lang yung mga sakit that will give you pulsus alterans assessment and the pulsus paradoxus assessment. Okay? Next, we have the respiratory rate. So respiratory rate record also the depth, the rhythm, and the breathing pattern. So the depth is kung gaano kalalim yung kanyang hininga. Deep breather ba? Shallow breather ba yung patient natin? IE ratio niya? Okay, 1:2 ba? And yung pattern of breathing niya, smooth ba yung kanyang pattern of breathing? And the characteristics, of course, of our respiration that is normal, is noiseless, regular, even, and without effort. Guys, if you know that you are breathing, then you have mild dyspnea or mild difficulty of breathing. Then usually, normal lang na tayo ay humihinga na hindi natin namamalayan, okay, that is regular and walang effort, and minsan nagbubuntong hininga tayo, nagsasay tayo 4 to 6 times per hour na hindi natin namamalayan without effort and kusang gumagalaw with our control of respiration na medulla oblongata and pons. Okay? So that is normal. Pero kapag ikaw ay conscious na with your breathing, yan ay meron ng dyspnea or difficulty of breathing. So respiratory center again, medulla oblongata, partly by pons. Yung nerve fibers natin, autonomic nervous system, where the sensory impulses are and which travel the nerve fibers to the respiratory center through the triggering doon sa ating vagus nerve, magsasend yan ng signal doon sa ating nerve fibers and will tap the pons and the medulla oblongata for breathing. Okay? Chemical composition of blood, small amount of carbon dioxide and greater amount of oxygen when breathing becomes quick and slow. Okay, so yung deep inspiration natin, expected natin na more ang ating tidal volume. And kapag shallow inspiration yan, expected natin na less ang kanyang tidal volume. Okay? Dahil nga kulang yung kanyang resting, breathing. So the factors affecting increase in depth and rate of respiration, again, the age, sex, emotion, disease process, exposure to extreme temperature, ingestion of toxins, okay, changes in latitude or altitude, ingestion of food, and exercises. Okay, moving on to the vital sign, blood pressure. This is the flow of blood against the wall of the artery, and it signifies the mechanical workload of the heart. So the pathophysiology on how this blood pressure is produced, we have the heart that will generate the pressure. So coming from the atrium and the ventricles, or the atria and the ventricles, and coming from the different valves. So magproproduce ng pressure. Okay, and this one, once it pumps blood, it will circulate to the internal organs through the blood vessels. So that pinapalpate natin yung kanyang radial pulse, pinapalpate natin yung kanyang brachial pulse para ma-sense natin kung meron nga bang blood circulation doon sa area na yon. Okay? So, we need to assess this blood pressure para sa circulation, checking of the circulation. So for the components of your blood pressure, you have your systole, which is the working phase, and it has the highest point. Yung 120/80, 120 is the systole. Diastole is the 80, which is the resting phase, and this is during relaxation. Okay, so kapag nag-BP ka, pinapakinggan mo kung kailan nawala yung kanyang pulso, okay? And kung kailan nagkaroon ulit ng pulso and nagtuloy-tuloy yung kanyang pulsation. So that is for your systole and diastole. Then, we also monitor the pulse pressure. The pulse pressure is the difference between systolic pressure and the diastolic pressure. So systole minus the diastole. And normally, it should be within 35 to 50 mmHg. Sa iba naman, 40 hanggang 40 mmHg lang na difference dapat. Pag nag-more than that, okay, ibig sabihin, there is hypertension or maybe masyadong may other underlying cardiovascular disease. Kaya papasok na yung ECG monitoring. So again, for the factors affecting BP, same lang halos, but with ito yung nadagdag, yung physical condition ng individual, the pumping action of the heart, resistance in cardiovascular system, elasticity of blood vessels, lalo na kung bata pa o matanda na, okay? Geria na yung ating patient, blood volume niya, kung siya ay, kung siya ba ay nagproduce ng maraming oxygenated blood, and yung viscosity of the blood niya, okay, dahil lagi siyang dehydrated, so kukunti na lang at yung kanyang fluid, and that's why nagkakaroon ng viscous dun sa blood niya. So prone siya na magkaroon ng hypertension and mag-cause din niya ng heart attack or ng stroke. And then, Korotkoff sound. Lumabas yung sa Korotkoff sound sa board exam, yung lub-dub sound. What is Korotkoff sound? This is a lub-dub. Lub for the systole, dub for the diastole, or yung kanyang pagpintig sa puso, lub-dub sound indicating systolic and diastolic pressure. Okay, so we need to be familiar with the equipments used in our blood pressure monitoring, the stethoscope and the sphygmomanometer. So we have several types na ng sphygmomanometer. Meron tayong aneroid digital, so tinanggal na yung mercurial because of the toxic effect ng ating mercury sa katawan once na masira yun or mabasag. So sa stethoscope, ang ginagamit natin, diaphragm pa rin naman, okay? Nilalagay natin yan dun sa brachial pulse. Yung bell naman, ginagamit natin to check for the apical pulse, for the PMI, point of maximum impulse. Okay, so ano pa yung other parts niya? May rubber tubing, earpieces, binaural, Y connector, open close twister valve. Okay, so as RT, dapat familiar tayo with the use of our stethoscope. Meron tayong type, single tube Nerscope and the Sprague-Rappaport. Okay, theoretically, ang Sprague-Rappaport is more accurate than the single tube Nerscope dahil binaural siya. Dalawa ang kanyang tube na malalaki yung tube. Kaya lang, mas maikli yung kanyang tube so that mas malakas ang dinig mo nung kanyang breath sounds o nung kanyang lub-dub sound. Okay? So, Sprague-Rappaport. But nowadays, meron na tayong mas effective din at mas portable dahil mas madaling isuksok sa blazer natin, sa bulsa ng blazer natin, yung single tube Nerscope. Littmann, yan. Number 2, we have sphygmomanometer, yan, yung aneroid and digital. Okay, and for the methods of measuring our blood pressure, we can do measuring of the systole and diastole via auscultation and via manometer and digital. But kung palpation lang yan, usually, ang namomonitor lang natin is the systolic pressure. Kasi hindi tayo gumagamit ng stethoscope and nagpapalpate lang tayo sa radial pulse and then nag-inflate tayo ng cuff. Kapag na-monitor natin na nawala na yung pulsation dun sa radial pulse upon inflation ng kanyang cuff, and then for a certain pressure, bigla nating i-release yung kanyang cuff pressure. And then, once na mapalpate natin na meron ng pulsation and nakita natin doon sa kanyang aneroid, doon sa kanyang gauge manometer, kung ilan yon, iyon yung kanyang systolic pressure. That is via pulsation, palpation. And then yung auscultation naman natin is the use of your stethoscope. Manometer, minsan kahit hindi na tayo nagpapalpate at nag-auscultate, tinitingnan lang natin, ini-inflate natin, dinideplate natin yung cuff, nakikita na natin yung paggalaw ng gauge. And for digital is automatic, okay? But this one will be altered by several factors like noise, o radio, or press, or mali ang kanyang pagkaka-cuff and others. Okay? Last vital sign is the pulse oximetry. A test used to measure the oxygen level, the oxygen saturation of the blood. It is an easy, painless measure of how well oxygen is being sent to the parts of your body furthest from your heart, so such as the arms and the legs. Okay, so meron tayong mga areas na pinaglalagyan ng pulse oximetry. So preferably sa middle finger or sa forefinger. Middle finger and dito sa hintuturo or sa forefinger. Okay? Make sure na walang nail polish. Okay? Make sure na maganda ang lighting dun sa area dahil affected din yung result ng oxygen saturation with those factors. So the SpO2 value must be measured from 93 to 99%. Lower than that, at 90%, suspect for underlying na hypoxemia. And kapag ang ating SpO2 has a value of 85%, okay, other methods could be used. Yung hemoximeter, ano pa mga dapat nating gamitin. Okay, so hindi pwede yan. Baka naman merong carbon monoxide poisoning yung patient natin. And dapat resort tayo sa ABG to determine it and or hemoximeter. Okay? Moving on to level of consciousness under objective findings pa rin. Nasa objective pa rin tayo under after na ng S, nasa O tayo. For the level of consciousness monitoring and assessment, so tinitingnan natin kung ang patient natin will exhibit slight decrease of consciousness, slow mental responses, pagka ini-interview natin o tinatanong natin, decrease or dulled perception or incoherent yung kanyang thoughts. Okay, so dapat na kausap natin, na-instruct natin para na-assess natin yung patient kung siya ba ay cooperative or confused. Okay. Next is delirious. For the delirious, easily agitated, irritable, and sometimes exhibits hallucination. So with this type, nag-hypoxemia na yung patient natin, okay, natataranta na yan, irritable na yan, and yung effect ng kulang ang oxygen is nag-hallucinate ka na. Minsan iba yung tingin mo dun sa object that is hallucination. Or iba yung pakiramdam mo. Okay? Nagsususpect ka for something na nade-threat ka, that is hallucination. Lethargic. Lethargic, ang lumabas sa board exam, obtunded. Okay. So meron doon nakalagay, decreased cough or gag reflex. What level of consciousness is that? That is obtunded. Okay, but take down notes na study also the other level of consciousness. So lethargic, sleepy, arouses easily, and responds appropriately when aroused. So lagi lang itong panayang tulog. Okay? And then laging naalimpungatan siya. Nagre-respond siya kapag nagigising. Okay. Pero hindi pa rin siya nakakapag-follow din ng instruction. Obtunded awakens with difficulty, always sleepy, responds appropriately when aroused. Okay. Patient is drowsy and has decreased cognitive reflex. So that is obtunded. So may difference siya between lethargic and obtunded. Yung isa, sleepy siya, okay, arouses easily. Ito namang obtunded, mahirap siyang magising. Stuporous, not awakened completely, decreased mental and physical activity, responds to pain, and exhibits deep tendon reflexes. So we need to assess yung kanyang deep tendon kung nagsususpect tayo for stuporous level of consciousness. Responds slowly to verbal stimuli. Okay, comatose type, unconscious yung patient mo, no response to stimuli, no movement, does not move voluntarily, and patient exhibits possible signs of upper motor neuron dysfunction, so such as Babinski reflex or hyperreflexia. So, naglo-lose ng reflexes yung ating patient with deep or prolonged coma. Okay, next we have this breathing patterns. Okay, so after mo, nasa objective findings pa rin tayo, na-assess mo yung vital signs, na-assess mo yung kanyang level of consciousness, yung general survey, level of consciousness niya, okay, the respiratory distress, now with breathing patterns. So, i-describe mo kung ano nga ba yung kanyang level of respiratory distress and possible breathing patterns. Okay? So, paki-picturean nyo itong slide na to, because you will need to study also kung ano yung causes ng ating condition. So, eupnea, we all know, is a normal breathing rate and pattern. For tachypnea, there's increased respiratory rate, more than 20 breaths per minute. So, kapag ang patient natin has fever, anxious, okay, from exercise, or due to shock, the patient will have tachypnea. Okay, mas mabilis lang compared dun sa pattern ng eupnea. And bradypnea, slow, decreased respiratory rate. And this is possibly due to drugs, deep sleep, metabolic disorder, head injury, or na-stroke yung patient mo. And apnea, ito yung kanyang picture. Kasi pwedeng ilabas nila yung diagram ng picture ng breathing pattern, and then sasabihin kung ano ang clinical condition. Okay? Now, for apnea, absence of breathing. So, this patient, syempre, mga patay na, may head injury, and stroke patient, minsan nag-apnea sila. Hyperpnea, normal ang kanyang rate, but deep ang kanyang respiration. That is hyperpnea. So when an individual has emotional disorder, stress, or diabetic ketoacidosis, usually hyperpnic sila. And Cheyne-Stokes naman, ganito yung kanyang pattern. So merong gradual increase and decrease, and then may moment of apnea, and then increasing, decreasing, moment of apnea. That is Cheyne-Stokes, gradual increases and decreases in respiration with periods of apnea. So, pwede yan doon sa merong mga intracranial pressure problem or brainstem injury. Okay? Next, we have this biots. So, biots as compared to Cheyne-Stokes, pantay yung kanyang inspiration. Meron din siyang moment of apnea. So, biots is a rapid, deep respiration or gasping with short pauses between sets of breathing. So, in cases of spinal meningitis, okay, CNS causes or problem, head injury, pwedeng magkaroon siya ng bios. Cosmol, laging lumalabas, is the deep and fast breathing. So tachypneic and hyperpneic in nature. So in cases of renal failure, diabetic ketoacidosis, and metabolic acidosis. So cosmol yung kanyang next spec. So kung ang patient natin has cosmol breathing sa ABG, so yun, expected na meron siyang metabolic acidosis. Apneustic is different from apnea. Apneustic is yung prolonged inspiratory phase with shortened expiratory phase. So lesion in brainstem could give us apneustic breathing pattern. Okay. So ito muna siguro yung ating last part of the presentation for today. For the objective findings, we have also to assess, di ba, yung kanyang color. When it comes to skin color, we are checking also kung decrease in color. Kung ashen or pallor in color, possible na merong anemia yung patient mo or blood loss. Kapag ang patient mo naman has yellowish in color or jaundice, possible lang, di natin sinasabi na yun nga mismo, possible na increase in bilirubin levels. Kung ang patient mo namumula, there is erythema, possible na meron siyang hypercarbia. And kung ang patient mo ay cyanotic, definitely, yan ay may hypoxia. Okay? So, check mo rin yung race specific niya. Baka naman Africano yan. Talaga namang maitim siya at medyo parang dark cyanotic. Okay? So, check the race specific. And also, after checking the skin color, you feel for that skin. Kung ang pasyente mo has a cold, clammy perspiration na pan-assessment, possible na yan ay may hypotension. Hindi natin sinasabi na may hypotension talaga yung patient mo, but possible lang. Pwede namang natatailang yan. Kaya nagko-cold, clammy perspiration. Pinagpapawisan ng malamig kasi pinipigil yung kanyang ihi o yung kanyang EBS. Okay? Warm to hot flashes, possible na ang pasyente mo ay nag-hypertension. Okay? Mumula. Baka during your chest physiotherapy, postural drainage, nakatagal-tagal niyang naka-head down position, ang pasyente mo, nagko-cold clammy perspiration, nag-hypotension yan. Okay? Naka-head down position, nag-warm to hot flashes na yung patient mo, nag-hypertension na yan. Ingat ka, baka mamaya ay mag-faint yung patient mo. Okay, so we will continue our discussion of patient assessment tomorrow. Dito na tayo sa slide ng functional classification of dyspnea. Okay? So I hope that you've learned dito sa ating first, medyo marami na rin na slides ng ating patient assessment, including our overview of the respiratory systems and yung ating mechanics of breathing. Okay, do you have any question at this point?
None so far, ma'am.
None so far. Siguro bukas meron na. Kasi purely ano naman itong ating discussion. Ang pwede ko lang maibigay sa inyo na tip. Lahat ng mga sinabi ko na lumabas sa board exam, aralin nyo rin mabuti yon. I hope that you jot it down na kung ano yung mga important or pertinent and significant na mga topics doon sa ating na-discuss earlier. Okay? So tomorrow, we will continue this one sa patient assessment and then meron sigurong post-quiz after this patient assessment tomorrow. So please be prepared for that post-quiz. Kanina, 10 points lang yon. Na-assess nyo na yung sarili nyo, di ba? Kung Kailangan nyo pa bang magbasa pa ng mas marami pa at i-recall pa yung inyong natutunan sa classroom? And during the lecture, ayan, dapat medyo nadagdagan na yung inyong information. And yung post-quiz natin would be from start until end nung slide natin na i-discuss tomorrow. Okay? So if you do not have any question at this point, the meeting is adjourned already. Sir Cap, i-end ko na ba?
Yes, ma'am. Okay na po. Thank you so much, ma'am.
Okay. So I'll see you tomorrow again at 3 p.m. Bye-bye.
Thank you.
Thank you, ma'am.
Thank you,
Bye-bye.
Thank you.